All right, we're going to do a quick little overview on ketamine because it's finally becoming more available now. Apologize. So, the biggest thing with ketamine is that it works completely differently than most of our other sedative agents. Most other things like Versed or Valium or Ativan work on the GABA receptor in the central nervous system to slow down conduction. This is the same receptor that alcohol attaches to and other drugs which cause mental depression and respiratory depression. Ketamine, on the other hand, actually blocks the excitatory receptor in the central nervous system, or the NMDA receptor. What this allows is to bypass some people who may have way too many GABA receptors from some overuse issues, might you say. But it also protects some of the respiratory drive and cardiovascular effects that we see as much more common side effects from agents that attach to the GABA receptor. Now, contraindications for ketamine. Basically, the only absolute contraindication is just a known allergy to the agent, and it's very unlikely you're going to know this, or the patient will know this, honestly. Now, one of the things is that ketamine can increase heart rate and blood pressure, and in the past, there has been worried to use it with people with head injuries due to the transient increase in intracranial pressure. Newer studies have kind of shown that it doesn't affect intracranial pressure as much as thought, especially from downstream clinical effects, and that therefore it's been much more accepted over the past 5 to 10 years in emergency medicine. The adverse effects, the main one that we worry about is going to be this emergent reaction, which is essentially a really bad nightmare. Now, if we're using it for RSI or for sedation and excited delirium, don't really care quite as much about that. And really, the emergency reaction is much more when it's used for either procedural sedation in the emergency department or in the pre-hospital setting with pain management. If you push it too fast or give too much, there have been cases where it will cause a apneic period or laryngospasm. Both these are generally self-limiting and can be overcome with just assisting ventilations. Hypertension and tachycardia are very, very common, though the clinical significance of this is minimal and generally it's self-limiting. So for our uses in the pre-hospital setting, there's basically 3 of our guidelines which incorporate ketamine. One of the biggest and probably most useful areas is just in sedation for cases of excited delirium. We also will use it as a secondary agent to narcotics generally with pain management. And then obviously our third as in our primary induction agent for our RSI. And we'll talk about each of these here. Availability, essentially what we're trying to do is to have a 50 and 10 solution. This may change somewhat based on availability, but the problem is if we go to more dilute solutions, if we're trying to give that in an intramuscular form, then you're having to give very large volumes, which basically prohibits its use intramuscularly. So we're going to try and maintain a fairly concentrated version on the trucks as long as it's available. So as far as the protocols themselves, again, sedation and especially in excited delirium is one of our main uses of ketamine. Generally, we're going to try, as you can see on the right with the kind of the flow chart of the clinical guideline, we're going to try Versed or a similar benzodiazepine first. If that doesn't work, then we're going to go to ketamine. In general, if you're using this for a patient who's in excited delirium, they're probably not going to be very cooperative, and I would recommend a quick route, and usually that's going to be intramuscularly. And that dose in adults is going to be 100 to 200 milligrams. For pediatrics, you need to contact medical control first for right now. For pain management, we're going to use it as an adjunct to narcotics. So you're going to try narcotics first. If that's not working, then we're going to try a small dose, usually 25 to 50 milligrams. Now, because of the likelihood of an emergence reaction, try and give this over a fairly long period of time, meaning a couple minutes. If you've got a small bag of fluid, 50, 100, 250, I mean, even 500, as long as you don't have any worry about fluid overloading the patient, put this 25 to 50 milligrams in that volume of fluid and let it run in over that time frame. Again, for pain management, we're contacting medical control for pediatrics as well. And finally, we'll obviously get into this more with the drug-assisted intubation teaching, but it is our recommended first-line sedative in our drug-assisted intubation guideline. We can use etomidate or Versed, but ideally we use ketamine. Now, ketamine does not cause the muscle relaxation that etomidate and Versed do, so you should practically always use it with a paralytic in drug-assisted intubation. But again, that's something we'll need to talk about in a broader scope. So if you have any questions, please feel free to contact me directly or via any of the routes below. Thanks.